All right, so good morning. I'd like to start with the case presentation today. So this patient is a 49-year-old right-hand dominant female who presents with immediate worsening pain, erythema, and swelling of the left hand after a cat bite. She states that the injury occurred 2 days prior to the presentation when she was feeding her cat Wooster. She knows that the cat is up to date on his immunization status, his rabies shots, things like that. She's got a past medical history significant for diabetes, hypertension, and depression, and she herself is up to date on her immunizations, receiving her Tdap booster last year. On exam in the ED, she's noted to be afebrile and have stable vital signs. When we inspect her hand, she has a 2 millimeter puncture wound on the dorsal aspect of her hand with scant serosanguinous drainage from it. There's diffuse swelling and warmth of the dorsal hand, nothing volarly, with streaking erythema going up dorsally to the distal third of the forearm. She has very limited range of motion of her wrist, secondary to the pain, but she's grossly neurovascularly intact distally. Her labs in the ED were significant for a CRP of 9.33. ESR and white blood cell counts were found to be normal. Radiographs of the hand were obtained and demonstrated generalized soft tissue swelling over the dorsum of the hand with no evidence of fracture or any foreign bodies. An MRI was obtained, which is coming up okay, which demonstrated significant edema of the dorsum of the hand and a small fluid collection measuring 2 by 4 millimeters under, just deep to the puncture wound. No tendon or bony involvement was noted on this MRI. So the wound was extended 1 centimeter in the ED and thoroughly irrigated with over 3 liters of normal saline, actually. It was packed loosely with new gauze and placed in a volar resting slab. She was admitted to the medicine service for treatment of cellulitis and started on IV Unison and monitored closely with serial exams. In terms of her hospital course, she remained afebrile with normal vital signs. The swelling and erythema were noted to be improved by hospital day 2. She was transitioned to PO augmentin and discharged on hospital day 3 with a 14-day course of this, with close follow-up scheduled. So in 1 week, she was followed up, and she was noted to, her symptoms were noted to be completely resolved. She was encouraged to finish her final week of antibiotics and follow up in 3 weeks just to make sure everything was still going okay. Of note, she has no animosity towards her cat. So today I'm going to talk about evaluation and management of mammalian bite injuries to the hand. So in 2010, Americans owned over 74 million dogs and 91 million cats. The true incidence of bites is actually difficult to ascertain, as many people who get bitten don't present to a medical provider. But it's estimated that 4.7 million people, or 1.5% of the population, is bitten by a dog every year. This results in an estimated direct annual cost of over $850 million, but doesn't account for indirect costs such as time off work, rehabilitation, or permanent impairment. In a lifetime, it's estimated that over 50% of the population will sustain a bite to the hand, greater than 90% of these being from domestic animals, the majority being dogs, cats, and the other being like reptiles and amphibians, things like that. 2 to 3% of these bites are secondary to humans. We've actually had 3, I think over the past week there's been 10 cases at the Reach. We actually took somebody yesterday to the ED for a human, or to the OR for a human bite, so it's something we're commonly seeing. So these bites are classified can be classified in 2 ways. So clenched fist injuries that we all know about, the fight bite, or occlusive bite. So clenched fist injuries occur from an impact of a closed fist against another person's teeth, and an occlusive bite is teeth from any animal, human or dog, cat, that closes directly on tissue, as you see there. So the clenched fist injuries are kind of unique, but they all present similar patterns of injuries because of the similar position of the fist at the time of the injury. And the vulnerability of the structure is there with that fist in that position. So with a clenched fist, the MCPs are prominent, with the overlying skin being taut with little soft tissue coverage. So as the fist strikes the person's mouth, the teeth penetrate deeply into the extensor mechanism and often penetrate the joint capsule, getting into that MCP joint. Then when the fist relaxes, when the patient lets go of that fist, the extensor tendon retracts from view, the capsular tear seals, and then this creates a closed environment that's ideal for flora to grow and can be located in multiple spots on the dorsum of the hand. So clenched fist injuries, as I said, should not really be taken lightly. As a superficial wound you see on the outside is typically just the tip of the iceberg. So in a retrospective review of 191 clenched fist injuries in 1987, Patazakis found that 75% of patients with clenched fist injuries had deep structure injury, the most being joint capsule violations in 70% of those patients. But also he saw tendon lacerations, articular bone indentations of the tooth going into where the tooth went into the bone, and then free articular cartilage fragments in the joint. Occlusive bites, on the other hand, present a wide variety of injury patterns, typically based on the type of the animal that's biting them and the situation in which the person was bit. They can result in anything from superficial abrasions to puncture wounds to larger crush injuries and even traumatic amputations, especially in the fingers. But in any scenario, the teeth often penetrate both the dorsal and volar skin and can inoculate the tendon, the periosteum, as well as the joint capsule. So in terms of dog bites, the severity of injury is correlated with a lot of factors. So the size, the breed of the dog, the circumstances of the injury, was it a provoked or an unprovoked attack? But it's important to know that the adult canine jaws can produce greater than 450 pounds per square inch of force. And their teeth are generally designed to clamp, crush, and tear their food. So these bites often result in extensive soft tissue damage, with overall infection rate in comparison to a lot of the other things being relatively low at just 2 to 15%. Cats, on the other hand, their teeth are designed for piercing and tearing their prey. And so they produce similar small puncture-type wounds that you'll see, contrary to the dogs, where their wounds are quick to seal and prone to abscess formation, making them one of the higher infection rates that you see with cats, weighing at about 30 to 50%. So when you talk about bacteriology of bites, it's obviously variable between species. Humans are typically the most notorious for causing pretty bad infections. Over 600 bacterial species have been isolated in human saliva. When you culture these wounds, they're typically polymicrobial with a mean of 4 isolates per culture. The vast majority are actually gram-positive organisms, so Streptococcus and Staphylococcus. But the Haysick species that we've probably learned about in medical school is also very common, with Eikenella being the most common of the Haysick group. Dog and cat bites, similar to human bites, cultures are often polymicrobial. Their mean isolates is about 5 per culture, and in both dogs and cats, the most common isolate is Pasteurella. So Pasteurella, this organism is isolated 75% of the time in both dogs and cats combined, which comprise over 90% of the bites that present to the ED. It's a gram-negative anaerobic pleomorphic coccobacillus. It's important to know about and be aware about, because if you're suspecting that this is going to grow, the laboratory needs to at least be aware that it is an animal that bit the person, as it requires special agar to grow, and it can actually take up to a week to grow. But it causes an early and severe inflammatory response that can present as early as 3 hours if the patient is inoculated with this bacteria. Tetanus is always something to be aware about. It's a slender gram-positive anaerobic rod that can grow a terminal spore. It's not commonly isolated in the mouths of humans, dogs, or cats, but it's a ubiquitous organism often found in the soil. So the potential for contamination of a wound is always there. It has a fairly wide incubation period from 2 to 38 days, but symptom onset, the mean symptom onset typically occurs between 7 and 10 days. Early symptoms of tetanus are just fevers, malaise, autonomic hyperreactivity, and then late, typically around that 10-day mark, you get the classic tetanus that we learned about in medical school, the trismus, the tonic contractions, and the spasms. So just to briefly touch on the treatment of tetanus, if you're ever in clinic and have this going on, you have the treatment recommendations are dependent on the current vaccination status of the patient, and they seem to be updated often. So booster vaccines alone are indicated if the patient has had greater than 3 doses of the vaccine in their lifetime, and their last booster vaccine was greater than 5 years from the time of the bite. Both the vaccine and the tetanus IVIG are indicated if the patient has never been vaccinated or if they've received less than 3 vaccinations in their entire life. So you have to give both the IVIG there and the vaccine in that case. So in terms of viruses that can be spread through bite wounds, it's obviously rare, but they're very serious when they do occur. So humans obviously capable of transmitting HIV, hepatitis B and C, herpes simplex virus, so the whitlow. Rabies can be transmitted by dogs, bats, raccoons, skunks, rodents. And in the lab, rats and mice and monkeys can transmit the hantavirus and the simian bee virus that you sometimes hear about in the news. So in terms of rabies, dogs are the most common source worldwide. This is typically seen in underdeveloped nations with large populations of stray dogs. In the United States, bats are actually the most common source. Raccoons come in at a close second, followed by skunks and foxes. But it's obviously rare in the United States. So in the past decade, there's only been less than 7,000 documented cases of rabies here in the United States. But worldwide, it's a much bigger problem and results in over 55,000 deaths annually. So rabies, it's a bullet-shaped RNA virus that's transmitted by saliva, brain, and nervous system tissue. So if you are contaminated with blood, urine, or feces, it's not considered to be infectious. It typically presents in two clinical manifestations. So the encephalitic form, or the form that you probably hear about and see, the type that Old Yeller had. You get fevers, agitation, hydrophobia, pharyngeal spasms, and hyperactivity. There's also a paralytic form that's less common, that you get an ascending flaccid paralysis that mimics Guillain-Barré. Rabies, if once you're symptomatic, it's almost universally fatal. There's not much you can do for people once they are symptomatic, which is why prophylaxis is always something to be conscious for. Also dependent on the situation. So here in the United States, if you're bitten by an animal, the guidelines right now is to attempt to quarantine that animal for 10 days. And if they become symptomatic, then post-exposure prophylaxis should be initiated. If it's initiated in a timely manner, it's considered to be 100% effective. So if it does become symptomatic, you administer a rabies IVIG actually around the wound and then at a site distal to the wound. It's actually a weight-based dosing. And then you undergo a series of rabies vaccines that typically occur on days 0, 3, 7, and 14. But it's important to know that the total cost of a rabies vaccine series for the patient is actually more than $1,000 out of pocket after insurance. So it's something very expensive, but obviously if indicated, should be obtained. So in terms of your patient history, you want to know what type of animal it was that bit them. You want to obtain the timing and the location of the injury, the circumstances of the injury. Was it a provoked or an unprovoked injury? Any immunocompromising factors such as diabetes, if the patient's had a splenectomy, any drugs that are on that could suppress their immune system, and you want to get a detailed immunization history. And as I said before, so symptoms of infection can occur pretty quickly within 12 hours of the bite. And in cats, you can actually see them develop earlier, such as in 3 hours of the bites in actually the majority of cases. On exam, you want to note the size and the depth of the wound. You want to note any devitalized tissue, carefully assess joint and tendon function. You want to obtain a detailed neurovascular exam and look for those signs and symptoms of infection. Of a side note, one of these papers I read said that in children, you should always be concerned for abuse if there's a human bite there. And one way that they said that you can kind of objectively do this is measure their intercanine distance, which is 3 to 5 to 4 to 5 centimeters in adults and 2 to 5 to 3 centimeters in children. But adult dentition is typically reached by 12 years, so it becomes less valuable after that. Your diagnostic workup, you always want to get plain films, look for fractures, any joint pathology, retained foreign bodies, teeth are there. MRI isn't routinely indicated, but can be used to better identify the extent of the infection if you think it's spreading and aid in operative planning. Laboratory studies aren't routinely indicated. You can obtain inflammatory markers to guide response or just see how the patient's doing, but not obviously routinely indicated. And then for wound cultures, acute bites should never be cultured in the ED, but if the patient does have an established infection, intraoperative wound tissues can be obtained, and then you should let the lab know what you're thinking about. So your management strategy is obviously going to be dependent on the size, the character, and the presence or absence of infection. Initial management strategies in the ED when you see these people should obviously be hemostasis, so you can apply direct pressure. You can use tourniquets, portable electrocautery, irrigation and debridement of devitalized tissue. The papers say at least 1 liter should be run through there. And then careful wound exploration under local anesthetic is probably the most paramount to see what's really going on underneath, as those flesh wounds can typically or always be the tip of the iceberg. And then hand wounds should never be closed. You should consider packing and soaks to keep that wound open and allow the infection to be gotten control of. And then the wound should be reevaluated in 24 to 48 hours until basically resolution. One study said that 91% of the time this can all be done in the ED and doesn't require a formal trip to the operating room. So quick note on timing and management. Basadre and Perry, back in the 1980s, conducted a retrospective review on 125 human bites. Patients were stratified according to the time elapsed from injury to when they presented to the ED. They stratified them into three groups: early, delayed, and late. Early being less than 24 hours, delayed being 1 to 7 days, and late being greater than 7 days. They found that the majority of patients who presented early underwent a local wound care in the ED only and had good functional outcomes, while those who presented late required operative intervention and still had decent outcomes but were worse than those who presented early. Fractures and tendon lacerations were seen in the early group, while infectious complications were seen: septic arthritis, osteomyelitis, and tenosynovitis in that group that presented greater than 7 days. And then the only thing that's interesting in outcomes are those that presented between 1 and 7 days. Their ultimate functional outcome was dependent on the type of initial treatment that they had when they presented. So those who just went local IND in the ED actually had worse functional outcomes than those who were taken to the OR and performed a thorough IND there. So in terms of antibiotics, it's something to be familiar with. Is you'll be in the ED and they'll often ask you, the physician will often ask you what you recommend that the patient go home on. And if you send them home on something else or you don't voice up, they might show up back in your clinic infected and requiring an operation. So routine antibiotic prophylaxis is not recommended for all bite wounds to the body, but it is recommended for all bite wounds to the hand. In 2001, it was a Cochrane review by Mierdos and Sakanato. They did a meta-analysis of 8 randomized controlled trials and found that hand and wrist bites were independent risk factors for infection. And if proper antibiotic prophylaxis is initiated, it actually reduces the risk of infection from 28% to 2%, with the number needing to treat being 4 there. Broad-spectrum antibiotics is recommended, as all these things are typically polymicrobial. So augment a penicillin with a beta-lactamase inhibitor is recommended for prophylaxis in most bites. Augmentin is the antibiotic for choice for human, cats, or dog bites. If the patient's allergic to penicillins, doxycycline, Bactrim, or fluoroquinolones can be used instead. It's important to note that you should avoid Keflex, dicloxacillin, and erythromycin, as these 3 antibiotics have poor activity against Eikenau and Pasteurelle, which are the most common isolates in any bite wound that you see to the hand. The duration of these antibiotics is also controversial. There's not really too many studies out there that look at the specific timing of these things, but in general, it's typically dependent on how bad the infection is. So simple cellulitis gets about 10 to 14 days of antibiotics. If it's a tenosynovitis or a septic arthritis, you're typically prescribed 3 weeks, and osteo, obviously, 6 weeks. Inflammatory markers can be used to trend the response to the antibiotics, but clinical observation remains the best measure of infection management. So then just a brief word on the economic burden of this management. So the cost of what seems to be just a bite can be profound for both the patient and the healthcare system. So Benson in 2012 conducted a clinical review on over 100 patients who suffered either a dog or a cat bite to the hand to assess the treatment of costs associated. So they categorize them into 5 categories. So if you can see it, if the patient presented and only had an ER visit with 1 IV antibiotic dose, 3 office visits, and sent home on oral antibiotics, that costs about $2,000. And if you go all the way down to the bottom there, where if they're at the ED and they're admitted for a bony debridement and tendon repair, PICC line, IV antibiotics for 6 weeks with 8 office visits and some hand therapy visits, that can cost a patient $82,000. So obviously, just a simple cat bite can get out of control pretty quickly. So in terms of functional outcomes, they're difficult to ascertain because these are obviously a heterogeneous group of injuries that depend on the type of bite, the time from injury to presentation, the presence of what's injured underneath. Patients who present early and are treated appropriately typically have few sequelae. If they present delayed or poor management initially, they'll go on to form persistent infections, advanced joint destruction, and ultimately with poor functional outcomes. So in summary, despite benign outward appearances, all bite wounds should be taken seriously. Bite wounds should be carefully inspected in the ED for bone, tendon, or joint involvement with local anesthetic if necessary, and then taken to the OR and fixed properly if they're present. Antimicrobial therapy is indicated for all bites to the hand and should be broad spectrum, as we talked about. And it's just good to know that early presentation is obviously correlated with the best outcomes. So we can skip our OID question in the presence of time. I thank Dr. Richard for my references. I'll open up for questions.
Great, that's a nice overview of something that we see treat occasionally, so it's good to go over that a bit. I have a question that's actually come up practically a couple of times with me about rabies treatments. Because the CDC guidelines say you're supposed to observe the animal that bit you, whether it's a cat or dog, for 10 days. A lot of times, at least the kids that I've seen with this, they come in and they don't observe the dog. So once they come to the emergency room, the CDC guidelines say someone has to observe the dog for 10 days before you start treating the dog. What do you tell people?
So I think you recommend that. It should be, and if that's not possible, I think you start to look at the circumstances of the dog. So.
Because usually they can't observe the dog. That's
right.
what happens.
So
they don't know the dog's gone, it's all gone, so they don't know who it is.
Yeah, and obviously the treatment for it is very expensive. It's often painful. Yeah, so I think you have to look at, it's obviously a judgment call at the time, but I would look at the circumstances of the injuries the doctor developed. Did they know the injury, the animal was, some friend dog was a stray dog and just attack. And if some of those, worrisome features were there that provoked injury, an animal hit the stray dog, things like that, and I think I'd be more likely to err on the side of caution and prophylaxis. But if not, I think you could probably clinically watch them, just have close call it. Because if they develop symptoms, like I said, it's typically an emergency fit, so you might have a quick treatment.
Comment, questions?
I applaud you because I think every resident in here, probably their OIT score just went up about 10 points. So, they're all testable questions and should be reviewed before the OIT. I think from a practical perspective, the biggest thing that you'll see when you, regardless really of your type of practice, you'll be faced with somebody who comes in with an acute bite and a rather significant amount of cellulitis. These are ascending, rapid, and associated with a lot of pain and distress, and you're always wondering whether to take the patient to the OR. In the case of a cat bite, I would say you probably should err on the side of going to the OR. They typically are very challenging to manage with just pure antibiotics alone. I think when your index presentation, you had an acute presentation, you did effectively a good IND in the emergency room, and you probably are to be applauded for that. But the majority of these are going to take a week at least to resolve with antibiotics, and the entire time you're going to be gnashing your teeth and being very anxious about whether you should have gone to the OR initially. So, in my opinion, just go to the OR. I think it probably, for a cat bite, you'll probably be happier and have more hair than I do.
You want proper lighting, proper sterility, proper extent of the wound to see, as they say, when you finish, you know what you've done it. With your hand, you go to
the most serious problems I've seen with this have been in the medical profession. Dentists or doctors, their cat bites, the cat teeth show like a hypodermic needle there. And they get bitten around the wrist, and they treat themselves with antibiotics, and then they can see you. The wrist needs to be fused.